Okay, so welcome everyone. Can everyone hear us okay? Thumbs up?
Yep.
Yep, okay, perfect. So we're just gonna ask that if everyone can put themselves on mute that are joining us virtually. Like Uzma had stated, this will be recorded for future viewing on our YouTube channel. So we do ask folks to turn off their camera just for their privacy. And you are welcome to change your name if you like. We'll give you a few moments to do so. And yeah, we have Dr. Patrick McVeigh, and we also have Paul Welsby joining us for our presentation on fistula or graft. We will also be taking you into an amazing simulation room to learn more about home hemo with those accesses by one of the nurse educators, Neural. So if you do have questions, we do ask if you can wait until the very end, and we will take your questions one at a time. So without further ado, we will pass it over to Dr. McVeigh and Patrick.
So my name is Patrick McVeigh. I'm one of the vascular surgeons at Trillium. We're a group of 5, all of us busy doing vascular access cases on a weekly basis. Here to provide some technical information about different types of primarily upper extremity access today and why you might go with one or the other. And
I'm Paul Welsby. I'm one of the renal access coordinators. So I work with the surgeons and the nephrologists dealing with renal accesses. I've been around this program now for 30 years and done odd different jobs, but right now I've been in vascular for 5 years. Okay, so we'll start with why choose a fistula or why choose a graft, and which one is the best one for you. So I'll just quickly explain the difference between a fistula and graft, and Dr. McVeigh will go a little more specifically about the types of surgery and how they're created. So a fistula is when you take an artery and attach it to a vein. We need to attach the artery to a vein to actually make it larger. Arteries can increase in size, but veins can. The type of needles that we use are fairly large to bring the fluid into the dialysis machine. So we need to increase the size of that vein, and we do that by attaching it to an artery. On the other hand, if your arteries or veins just aren't quite big enough, or there's anatomical issues, we will put a synthetic material in, okay? And it's still attached to an artery or vein, but there will be a synthetic material between.
No audio, guys.
Okay, sorry guys, so what is a fistula? A fistula is when we connect an artery to a vein. There are different areas that we can create a fistula. One is at the wrist, which the fistula would be in the forearm. And there's 2 types of fistulas that we can actually create in the upper arm. Next slide, please. Okay. A graft, on the other hand, can be in the forearm or the upper arm, and also we can put a graft in the leg. Okay, and it is the synthetic material, fiber material that is woven that we actually put the needle into. And Dr. McVeigh again will talk a little bit about the different types of materials that we use, but it can be in the forearm, upper arm, or in the leg. Currently, just so you know, the leg isn't used very often. Out of the 225 accesses we have, we only have 1 graft in the leg. So why would we choose a fistula over a graft? Fistulas do have a lot of positive points about them because they're a natural vessel. And as a natural vessel, when you do cannulate into them, when you pull the needle out, it has natural healing. So it actually heals around that area, and the vessel can heal itself. They also have less infections than grafts. And also we're not talking about our central lines, but they have a lot less infections in our central lines. The good thing also about a fistula, because it is natural, it can last up to 7 to 10 years. And there's also less clotting in the fistula. Because they're not an artificial material, they don't seem to clot a lot. We don't have to declot a lot of fistulas in interventional radiology. What our concerns are about the fistula is, though, it takes longer to mature. Because you're connecting the artery to the vein to make it larger, it doesn't happen overnight. So we're looking at an 8 to 12 week period for that fistula mature. So if you have to go on dialysis right away, this wouldn't be the option that we would take, okay? Veins also need to be a certain size. A lot of our patient population are diabetic, so their veins are usually a little bit smaller. We do have a recommended size that we have to have before we create a fistula, and your veins just may not be large enough to create a fistula. They generally are more difficult to cannulate when we start, but once we get them going, they are the better access. I say they're more difficult to start because a graft, we will be able to make that, when we put the graft in, it'll be a straight line and a little bit of curve. Well, with a fistula, we never know. It can curve, it can turn, it can increase and decrease in size. So we have to wait for it to mature to get the sites that we need to, okay? With both fistula and grafts, we can have something called Steele syndrome. Because we're changing the flow of the blood to the hand, sometimes we may take a little bit too much blood from the hand. It can cause Steele syndrome. What you'll do is a decreased circulation in the hand. You may get pain, you may get numbness related to it. And in severe cases, we actually have to tie off the fistula or graft and maybe do a surgery to correct that. As talking about Steele syndrome, out of the 225 patients we have, we're currently following only 11 patients with a Steele syndrome issue. And most of them, 9 out of the 11, we're just monitoring it. We're not doing anything about it per se. Next slide, please. So why would I choose a graft over a fistula when the fistula is natural and all that? It's the vessel size. If we don't have the right vessel size, we can create a graft, which is better than a central line. The other good thing about a graft is we can actually use it sooner. We can use it to 2 to 4 weeks. And the size of the graft tube is already set. It's at 7 millimeters, most of them, yeah. 7 millimeters are most of the graft size, so we're not worried about it getting large. It's already there, it's set, and we can use it, okay? There are some more major concerns with the grafts, and one of those concerns is because it's not a natural material, it likes to clot. We are declotting grafts more often. We do probably a declotting once or twice a month of a graft, and we only have 25 grafts in our system, so it is a higher rate of clotting. We can declot them and use them again. It's just that you have to go to interventional radiology to do that. The other issue with grafts is, and Dr. McVeigh will talk about how you actually put the graft in. You have to tunnel underneath the skin, and this causes a lot more swelling, okay? So compared to a fistula, which hardly gets no swelling at all, the graft, you can actually have some moderate swelling in the forearm, and that's actually most of the time what is stopping us from using it if there's too much swelling related to it. The graft is fairly good as far as lasts long, 5 to 7 years, and that's very important that we move the needles around in the graft so we don't chew up the graft. We don't want to put it all in one spot. We want to move it around so we don't wear the graft out. Because once you put a needle in a graft, it doesn't repair itself like a vein does, okay? So we always want to move the sites around. The more we move the sites around in a graft, the longer it lasts. And the same thing with the Steele syndrome, because we are changing the flow of blood to the hand, it may give you the Steele syndrome, which, as I said before, is painful. It decreases the circulation, may give you numbness. Next slide, please. So I just wanted to kind of give you an overview of what we have at Trillium Health Partners. We have 225 accesses, 20 are fistulas, and 25 are grafts. So as I said, if we have the choice, we will create a fistula first because it is a better access. It will last longer. over time, it's the better access to have. We don't have the complications with the clotting. Okay, so I kind of looked at what we have done over the last 3 months. So we've created 15 lower arm fistulas, 4 upper arm fistulas, 3 grafts, and we've done 1 drill procedure to correct that Steele syndrome. Okay, and we've done 9 revisions. So the 9 revisions are when the access gets a little bit old and you may form what they call aneurysms. The doctors can look at putting little pieces of graft in there to make the access keep working. So out of that 7 to 10 years, you may have to do another surgery later in the years to keep the access going. Okay. As I mentioned, we had 3 declottings in the last 3 months. So 1 declotting a month for the grafts, which is a fairly, okay. So what do you expect when you come up? You come upstairs at Credit Valley Hospital on the 3rd floor, and you'll meet the surgeon and you meet one of the vascular access nurses like myself, and we're going to talk to you about the surgeries. So what we talk to you about the surgeries are, first of all, the procedure takes anywhere from 45 to 60 minutes. Grafts takes 60 minutes? Yeah, okay. Grafts 45 to 60 minutes. The whole procedure itself will take 4 to 5 hours. There's an hour there where you come in and they do all the paperwork, they put an IV in you, make sure consents are signed, do whatever, the blood pressures and all that. And then the procedure itself will take 45 to 60 minutes. And then afterwards, because they give you medications to sedate you and decrease your pain, you're going to be there probably another 2 hours before you're released home. Okay. It's very important that you know that you have to be accompanied through this process when you do go home, because you have received some sort of pain medication and meds to make you relax. Okay. Most surgeries, fistulas are done under local anesthetic. Grafts are almost always done under a regional anesthetic, so where they would freeze the entire arm or area in the leg they were working on, or with a short general anesthetic, depending on where exactly the extent is that's being put in. It can be difficult to freeze the arm all the way up into the shoulder very well. And so often if you're having an upper arm graft that's coming into the big vein in your armpit, you may end up going to sleep very quickly, although that decision is sort of a shared decision between the patient and the anesthesiologist, because often the needles to freeze your whole arm are worse than just going to sleep comfortably. So, but it really depends on your other medical issues, how your breathing is, and that as to which is the safer option and what will be most comfortable for you afterwards. So do remember though, as I said before, like 200 fistulas compared to 25 grafts. So most of the time it will be local anesthetic. The incisions are very small. They're either at the wrist or at the elbow. They're about 2 centimeters in length. They're going to have internal sutures on the inside. You're going to have steri strips on top. Okay. Grafts, you're going to see more incisions because they have to tunnel. Okay. And same thing, they'll have the dressings on afterwards, or just little me-pour dressings. Okay. A lot of the time we will stop your anticoagulation unless you've had a stent or something put in your heart or other places. We'll usually stop your coagulation before the surgery. Fistulas, you can take the dressing off 2 days afterwards, okay, and you can wash the arm 4 days afterwards with soap and water. With the graft, sometimes they'll have a special dressing. It's an antibacterial proof dressing they're using. It looks like a honeycomb. Those dressings we actually leave on for 5 days, and we pull those off afterwards. Okay. You can use the arm for about a week, use 10 pounds weight, so you can use it. It's not like you can't, use your computer and that stuff right after the day after surgery, and then you can go back to using the arm normally after the first week. Next slide, please. So post-operative fistula care. Did we miss a slide? What's in there?
No, it was pre.
Okay, that's okay. So, okay, I divided the fistula and graft for the next part. Okay, so I'm gonna go to the postoperative and then you can talk
Yep.
afterwards, okay? So the postoperative fistula care, as I said, 2 days after, you can take the dressing off. You can have steri strips over top, okay? Those are gonna fall off in about 7 days, and if they haven't, you can peel them off at that time. As I said, the sutures are internal, so you'll actually see, it'll look like a little bump that will dissolve with time. The sutures take 2 to 3 months to dissolve underneath the skin, okay? Avoid touching the area, even though you can wash it. We don't want you to touch and feel it all the time because it increases the chance of infection, okay? I talked about the sutures already. Make sure you're feeling for that thrill. It'll feel like a pulse underneath the skin. You notice it's a lot larger than what it was before the surgery. We just want to make sure it's working. If it's not working, you need to contact the access team, and we'll talk with the surgeons on different ways we can deal with it, whether it's through interventional radiology or they'll have to go back to surgery. So after you have a fistula created, we're looking at seeing you 2 weeks afterwards. At that 2-week period, what the main thing we're going to do is make sure the site is not infected, it's healing well, and we're going to look at doing exercise. It's very important to do exercises with the fistula. It's going to make the fistula bigger, and the more exercises you do, the quicker we can actually use it, and it also increases the size. It's very important that you do these exercises when we talk to you at the 2-week period, okay? At the 6 to 8 week period, we're going to bring you back for the first time, and we're actually going to do an ultrasound on your access. This ultrasound will see what size it is. We're looking for at least 6 millimeters. And that'll be large enough to put needles in. If it's not large enough at the 8-week period, we will wait another 4 weeks, and we will look at it then for possibly starting with the needles. Okay. Just note during these times at the 8 to 12-week period, we may find little narrowings in your vessel, and to make these narrowing bigger, we may send you to interventional radiology and do what we call a ballooning. And those balloonings just increase the size of the areas so we can get better flow through the access so it matures better during those times. So you may have a little procedure in radiology in between the surgery and actually starting to use the needles. Okay? So postoperative graft care, it's very similar, but as I said, sometimes they'll have the bacteria-proof dressings. Do you use those?
All the time.
All the time, okay. There's 2 or 3 surgeons that use them all the time, and there's a couple of surgeons that don't use them. Without any sort of artificial material, we're always worried about infections, so using these honeycomb things help prevent any sort of infection after the surgery. We can take that dressing off after 5 days, and you can wash the site as normal. There will be steri strips underneath it. You wash with soap and water after the dressing comes off, okay? Again, avoid touching it, just like the fistula. I talked about the raised areas. There are going to be more raised areas because there's more incision sites with the graft, okay? And again, they're internal sutures, and those will diminish after 2 to 3 months. If, when you do have swelling with the graft, try to raise the arm. Like if you're watching TV, put a pillow underneath it. Keep it about the level of the heart. We don't want you to hang your hand up in the air, but if you just keep your arm at the level of your heart with pillows underneath it, that will help drain the access. The other thing, if you are a dialysis patient, to decrease your fluid, not decrease, but maintain your fluid intake, on dialysis, try not to go over your normal amount of fluid. That will help so fluid doesn't build up in your arm, okay? There's no need for exercise for your graft because it's already opened up, so we won't do that with you. But it is very important, as I said, to move the arm like normal. We have had patients that protect their arm because it's swollen and they get elbow and shoulder problems because they stop moving their arm, okay? We want you to keep moving that arm. Also, when the muscles are pumping in your arms, they actually push the fluid out. So make sure that you are moving your arms like normal and doing normal activity. Again, you want to feel for a thrill every day or a pulse on your graft. And if it's not working, you should contact the vascular team. And as I said, because it's not a natural material, we're going to see you because it is a non-natural material. What did I say?
You can't use the double negative.
Yeah, it's not a natural material. We can actually use it to 2 to 4 weeks. So we'll see you after the surgery, 2 to 4 weeks. And that'll be maybe your only appointment that we actually see you. We don't need to see you at the 6 and 12-week period. Okay?
I think that's it.
Yeah, that's it.
So I thought maybe I'd just talk briefly about, from a surgical perspective, a bit more on a couple of those points for why you would choose one or the other and what you can and can't sort of change about yourself when you come for access creation. I think we have a fistula first, if feasible, sort of program orientation, because that's what's been shown to give you the most durable, long-lasting, anti-thrombotic, most reliable access for years and years. But you need to have an adequate artery and vein in order to create a fistula that's going to work. And this is often the rate limiting step, is that, if you were to imagine that, when we make that connection, when we put the pressure of the artery that's buried deep in your arm into the vein that's right under the skin, let's say a vein triples in size. If you start with a vein that's 3 millimeters across and it triples, it's going to get to be 9 millimeters, almost a centimeter across. That right under your skin is perfect for needling reliably, easy to grab, easy to put pressure on afterwards. That's perfect. But if you come with a 1 millimeter vein and it triples in size or it quadruples in size, it's still going to be a small vein. And some people just start with small veins. And we know at that first initial meeting, when we're looking at it, that your forearm vein might just be too small to use. So what do? Well, we can look in your upper arm then, and maybe your vein is a bit bigger there. And we would try and make the connection at the elbow to mature a fistula in your upper arm. We've talked previously in this setting about how most people have, even if that arm is beat up, you've got a really good vein that runs on the inside of your arm that's not readily accessible for needling, but that can be, if it grows to be big enough after making that first connection, it can be moved to the outside of the arm to give you a great big fistula on the outside of your arm in a place that's easy to work on, but that requires 2 procedures to do so. We'll always pursue a vein like that fistula as our primary access, because it does give you the most durable thing. The caveat being, if you're interested in dialyzing at home, there's concerns depending on your individual setup. It may not be ergonomically possible to access a fistula on the outside of your non-dominant arm and hold pressure afterwards, in which case we may look at you, and this is why everyone's sort of fistula decision is not protocolized. You don't just tick 4 boxes and then you get this. We look at you and how you're going to get dialysis and who's going to be involved in doing that for you and where it's going to be done to pick what will work best for you. Because if you come with small veins, but you've got a good one on the inside here, but you're planning on dialyzing at home and you want to do your own cannulation and decannulation, like, you're not going to be able to do that. And so how could we give you an access in your forearm? Well, the solution is, if you've got good blood flow in, if it looks like your artery is good and you just don't have a big enough vein, we can use the graft, which is essentially, you can view it as an artificial vein. In contemporary practice, these are all made out of Gore-Tex, and they come at a size that you could do dialysis right away. So you'll get an incision that brings it to the artery and vein, and then usually at least one small counter incision that lets us bring it in a gentle shape. And unlike a fistula, where you usually are looking to create a straight line segment that you'll cannulate in, either one straight line in your forearm or one straight line in your upper arm, A graft may intentionally have a rainbow shape in the forearm or a gentle rainbow or D shape in the upper arm to give you more length of graft in which to have cannulation sites. Since, as Paul highlighted, we generally want to rotate in grafts a bit more because the needles are going in and out of this prosthetic material, and the tract is being sealed just by your skin and subcutaneous tissue on top of it. So we don't want to be repeatedly creating a tract because there's nothing to heal on the inside, and if that tract gets matured through your skin, it may be very difficult to, if you've made Swiss cheese of a graft, it has no capability to heal itself, unlike your own artery and vein that can continually renew itself. Grafts come sort of in the usual that can be accessed. We usually wait for a scar in that to form on top, so wait a couple of weeks and then they're ready to go. We do have early access grafts that are designed to be accessed within 24 to 48 hours of surgery to try and avoid people getting a line, or people where a line isn't an option. But those circumstances are very rare. The goal being to identify people pre-dialysis and get ahead of that lead time that Paul mentioned for the fistula, right? The best case fistula from the day you're seen in clinic isn't going to give you dialysis for a couple of months. So if you need dialysis now, your options are either going to be a graft or a line as a bridge to a fistula. So you will want to be starting the ball rolling on a fistula as soon as possible, because the other unknown is often, you've lived your whole life not knowing that you needed this vein in your forearm to create your lifeline for access. And that thing will have been needled for testing and blood work and all this stuff. And it looks fine in the ultrasound. And then we pressurize it. And as Paul intoned, it may grow and swell, but then there's going to be some scars from where you had, blood work a number of times, and those areas don't grow. And that's like putting your thumb over the end of the garden hose, right? It limits the amount that comes through and it increases the speed. And so you can end up having a nicely matured fistula for a short segment, but then maybe there's a branch that is stealing blood flow away, or a scar from previous access for blood work that's really limiting the whole thing becoming big enough. And so that may need a secondary intervention like an angioplasty or a clipping of a branch, which further adds time to it being ready to use. And so while it is the most reliable long-term thing, it is not, you can't just buy it at the store and get it ready to use. Like a graft we pull off the shelf and it's perfect. It was made by a machine. But, the fistula is a sports car. You got to look after it, and it takes some work to get it going. But then once it's going, it tends to be the thing that will keep going the longest because it's all your own tissue. As Paul said, almost all of the initial accesses are created under local anesthetic alone, just with some sedation. Whereas grafts tend to require a bit more of a block just because of the way it's brought under the skin. I will not pretend that this is like laser or robotic surgery that's done with like microscopic stuff. It's done by making two cuts and shoving a metal rod under your skin between them, tying the graft to it, and then pulling it right underneath. So your arm swells quite a lot, and that is the rate limiting step. Everyone's graft would be ready to use 2 days after it's put in, except most people get so much swelling around it that they're kind of doing the two pillows for a couple of weeks before it drains. But it could probably be accessed with an ultrasound if you needed it beforehand. But really, like I said, and the theme here is that decision making is personalized. It's not protocolized. But we will always choose an all you access, one that's made just of your own parts, because we know that is the most long-lasting option for you. But in many cases, socially, a graft may be the best choice, or you may just be out of veins. And we'll sort of talk with you about, well, do you want to have a fistula, but it's in your right hand and you're right-handed, and that's going to limit what you can do during access? Or do you want to have a graft in this side and accept that maybe it won't last you a decade, but then you've got however long using this side for? It's very personalized, the decision making, and you have a voice in that decision making as well. Okay.
Actually, that's an important point that I did miss, is that we always look at the non-dominant hand first. We're going to look at creating the access there so you can keep your dominant hand. When you're on dialysis, you want turn the TV channel, you want to play with your phone. So we always look at the non-dominant hand first. Okay. The other thing I want to mention that you were talking about, if you're a pre-renal patient, we're looking at a GFR below 12 before you're actually brought into our clinic, because there is such a thing as creating it too early. So we look at a GFR around 12 before the nephrologists actually refer us to the vascular surgeons.
Yeah, and many people who come in as a pre-dialysis patient, you'll have your initial consultation and we sort of decide together what we're going to do. And if it's a fistula, then we might start the ball rolling on it, because you could be looking at, 4 to 6 months to have a reliable access if you need a secondary procedure, or if the decision is to do a 2-stage in the arm. Whereas if the decision is a graft, we may just send you away and say, come back when your nephrologist thinks you need to start in a month, because you don't want to, whereas you'd much rather have you with your fistula humming and ready to use when you need it. You don't want to put a graft, if a graft is going to last you 7 years, you don't want to put that graft in 6 to 8 months early and take that off your back end when you might need it. You're going to start a graft much sooner to when you're planning on actually starting it, to the extent that anyone can plan to be on HT. But the goal of either of these is to avoid the placement of a tunneled centrally accessed vascular catheter, which comes with their own host of complications and problems. So the idea is to get out in front of it, but the actual procedure depends on you and your particular anatomy, and is subject to change and revision. This is very much a personalized thing, and the amount of growth that exists within your own veins is sort of to be determined. And we've had everyone who in our group can think of someone with a perfect looking vein on their ultrasound that just won't grow and is stubborn and stuck and refuses to turn into a fistula. And I have personally been surprised by some where we start with a very small vein, but in a young patient, not a transplant candidate, looking at a long time of access, well, we'll try it, and it just leaps up to size and works well. So it is very personal, and because of that, there is a time lag built into it. So there needs to be some patience and participation in the process on the part of the person having their access created.
So we do have questions.
Sure.
All right, so one you kind of answered, are revisions needed more for a fistula or a graft?
I think that, when you think of a revision, you have to think about why, what are we talking about? So as Paul alluded to already, fistulas rarely fail for thrombosis. So once they're working, they rarely clot. But what happens is that same pressure that causes them to dilate in repeated cannulations can cause some segments to be overly dilated, become an aneurysm. If you look around a unit, there'll be some people with big aneurysms and that. When they get to be problematically large, they may need to be revised by removing that segment and placing a short graft in the middle. Whereas grafts, their typical mode of failure is they work fine and then all of a sudden they clot, and those may need to be declotted, and that's done by a radiologist usually. But revision can also mean at the beginning, right? So a graft is 2 cuts, and so long as you brought a reasonable artery and vein somewhere in your body, we'll connect them with the graft and it works right away. And it's going to work until it clots. Whereas a fistula, you make a very simple connection at the outset, but as it grows and swells, we may find areas of narrowing that weren't evident originally that need to be angioplastied or stretched. We may find branches that you couldn't even see on the ultrasound. They're so small at the beginning that suddenly, now that they're under pressure, become huge and start stealing flow out of your fistula and not making it grow up. So revisions after fistula creation are not uncommon. And, I quote somewhere between 20 and 30% chance of needing a secondary procedure at the time of access creation to get it to mature. Whereas revisions are never needed for a graft because it comes perfect and ready to use out of the box. But on the backside, fistulas age and require maintenance, and that, whereas grafts tend to just kind of hum along until they just stop working. And so they require different types of revisions. But as Paul sort of showed, fistulas clot rarely, and grafts, there's a certain steady volume of grafts that require, or that, you know, the goal is to not have either of them clot. During dialysis, flows and pressures are monitored. And if we see signs that a graft isn't working well, that the pressure as we try and shove the blood back in with the machine is going up, or if the flows in the graft as measured with ultrasound start going down, these are signs that it's going to stop working. And the access team will coordinate for you to have hopefully a diagnostic fistulogram done by a radiologist where they may be able to see a narrowing in the vein or something like that that's choking off flow and stretch it before it actually loses. And I think the relative frequency of each of those is variable because they have different modes of failure. So both require ongoing maintenance, but the types of procedures that are necessary vary between them.
And what are some of the reasons why it clots?
I mean, I would say that a graft will always be a foreign body. And so some people have a more vigorous reaction to a graft than not. Contemporary grafts have heparin and anticoagulant bonded to the inside to reduce platelet sticking to it. And over time, we know that when we cut grafts out and we look at them under the microscope, you can see native cells that line blood vessels have grown into the inside. So the foreign body reaction should go away after a while. But we think that, you know, people whose pressures get very low, you get stagnant flow in big aneurysmal sections or in big grafts, that can cause thrombosis. Hypercoagulable states brought about by illness or cancer or other things going on in your life can cause it to go down. But I think the biggest cause of thrombosis is probably reduced or stagnant flow. And so in people who have stenoses or narrowings in the segments that drain your fistula or graft, that causes pressure to build back up, and blood that isn't moving quickly clots. That's how you live, right? When we pull your needle out and you're bleeding, it's flowing blood. It's not going to stop if you just like stare at it. It keeps coming out. We put pressure on it. That slows down the flow of blood. Slow flowing blood will clot and stick together. And the same thing happens on the inside. If you have slow flowing blood that's swirling around, that's sitting in a big aneurysmal segment, it's going to stick to the wall and clot. And so clot forms in them no matter what. When we do ultrasounds on big fistula aneurysms and that, there's plenty of thrombus in all of them. And so
just to add to that on the hemo side of it, people that come in with large fluid gains that drop their blood pressure during dialysis are a cause. People that have really low cardiac output. If like we have some that have flows that are in the 2000s, but then we have some grafts that only have a flow of 500. So they're at a higher risk. So if you have a poor heart function, that could be a reason for clotting. And as I said, on dialysis, if you take off too much fluid, your pressure drops, it increases the chance of your access clotting because your pressure is so low.
Dr. McVeigh, you did kind of talk about this, but we have a question. Can you have your veins assessed before EGFR less than 12 so you know which access would be ideal?
I'll answer that one. It's not necessary. At the 12 mark, we're not going to do anything different if we had it accessed earlier. You know, we can problem solve at the 12 GFR of 12 and deal with any issue before you actually have to go on. So we don't really need to do it earlier.
if your GFR is double digits, just enjoy being away from the access clinic and come when it's time, you know.
Next question is, can you swim with a fistula or a graft?
So the advantage of both of them is that they are both under the skin. And so if you have healed on top, unlike a central line PD catheter or something where there's this permanent connection from the outside world to the inside, yes, these are covered by skin and you can be fully submerged. Just some programmatic caveat.
Yeah, I was going to say it's always safer to swim in chlorine and salt water compared to a lake, because lakes have bacteria. So if you had a open wound on your fistula or something, you shouldn't be swimming at that point. If it's a normal after dialysis, yes, you can. But as I said, it's safer to swim in chlorinated or salt water compared to a lake or a pond.
All right, if we have any questions from the audience, you are welcome to raise your hands and then we can go one by one from there. And if there's any other questions in the you want to put in the chats, please do so now. Just give it a minute. All right, no other questions. So what we'll do next is we'll go to our simulation room and we'll kind of show you guys what.
Actually, maybe there's one more thing we can do beforehand.
Go ahead.
We have two people here with fistulas. Yeah, I would really like their input on how it started using their fistulas and how they felt the process was.
Okay. Sure. Well, I started out with catheter, and then I developed a stenosis. So that's when I went to fistula. But fortunately, when I started dialysis, we put the fistula in, so I was able to use it for a year. Okay, does that make sense? Yep. Yeah. So, and so far it's gone well. Mine's in the upper arm. I can show you too. Yeah, it's in the upper arm. So the rashes around here because I was allergic to package that I was putting on. So I'm just working through that now. But it works really well. The pressure in it is pretty high. I don't know if it's over 1800. Yeah, so it's pretty high, but so far I haven't had any problems.
So people quite often ask about the pain in the needles. So what are your thoughts on cannulating with the needles?
It's painful, but I've gotten used to it. So, and I know my arm now. I know where is more painful and where is less painful. So it's fine.
So one way I like to phrase it, it's just like getting blood work, the first initial prick, and then it goes away once the needle eventually goes in the skin. And during dialysis, you should not feel any pain. And if you do, you talk to your vascular team or your nurse to adjust it because it's probably touching a wall or something to that effect. But it should not hurt during dialysis. And you do get fairly used to the needling at that point
You
too.
know your arm after a while.
Yeah, I agree with all of that. As far as the needles are concerned, my approach to it is that I know it's coming and it's mind over matter. And if you control your mind and know that it's going to last for a short period of time, it helps. As far as my fistula is concerned, Paul was the one actually that worked with me. Yeah.
That looks good.
Yeah, and what I was told was that they start in the lower part of the arm in case there's any issues, and then of course you have the rest of the arm to work with going forward. The procedure, I mean, it's painless. The pain comes afterwards, and it's not that it's not that difficult.
So after the surgery, that's a good point, is most of the time we just suggest using Tylenol plain. Because of the small incision site, it really, Tylenol plain usually is good enough to cover the pain. So.
And by the way, I do home hemo, so I put in my own.
Well, that's good for you.
Good.
I have a nice one, so it helps.
So we do have another question in the chats. How did the doctor determine which part of your arm will the fistula be located?
So I think it's a balance of, we look at, you're right or left-handed, where are you going to do your dialysis? And then, as was alluded to, we usually try and start as far away as possible and work our way up, because if you make a connection down here at the wrist and you get 7 years of service out of that, on the 8th year, you can come to the upper arm, and because there's been so much flow coming from far away to be more proximally, you often find that the vein there is enormous already and may be ready to go. Whereas if we start up here in the upper arm and you get 5 years out of that and you beat up that outflow, you could make a fistula at the wrist again, but it's going to be running into that segment that's not working anymore. And so it's unlikely to be successful. So we'll always start far away and come closer, but we'll, using that as an organizing principle, we come to you and say like, all right, your vein in the forearm If it looks great, then that's the place you should start. But if it's kind of on the borderline, but your GFR is okay, then maybe we try it here because we accept you're going to need a secondary procedure and it's going to take you 4 to 6 months to get working. But if we do, then you've got a foreign fistula that works well versus, you know, if you come with small veins here, your GFR is 9, you're getting short of breath. I'm worried you're going to get a line. I want to minimize your line time, but you got a good vein in the upper arm. We're going to start there. And so the organizing principle is non-dominant hand first as far away as possible. And what do we need to do to stick with vein only? But a lot of that will be individualized to your particular clinical situation to decide what's the best fit for you.
Can we briefly just talk about how not to Google?
Try not to go there.
Yeah. I mean, the only things that are going to be on the internet are going to be pictures of like ridiculous fistula aneurysms and all the problems that people have. But like, there is no ill intent among the access program here. The reason we have such a huge number of people with fistulas is because that's what works well. And the other thing I would say is avoid the sort of center envy. When you see people with lines who come in and get clicked together with 2 twist locks with no pain, and you have your dialysis, and when you're done, you get unclicked and it disappears under a shirt and they walk away. And you see people with, you know, their fistulas are holding pressure for a while and then it's bleeding or holding again. What you don't see, because in centers only people who are well and doing well, are all the people with central venous stenosis, recurrent line infections, and all those problems. I mean, Paul, what are the numbers for infections?
So, yeah, I always bring up this point when I talk about the choices. So we have not had a fistula infection that we had, you know, any problems with in the last 4 years. We have 3 line infections every month at least. Okay, that's our average right now. Okay, it is, if you're looking at the causes of mortality and morbidity in dialysis patients, infections is the second cause below cardiac. So it's very important. If we can eliminate that infection part, you will have a longer life on dialysis. So that's why it's so very important to look at a fistula graft over a central line, even though it is a lot easier to hook up than that. And you have to remember our stats for lines. If you look at what we do in interventional radiology, we're dealing with 5 in-line insertions a week, and that means we're replacing them. So a central line usually lasts on the average only 1 year before we have to replace it. And as I said, once we get a fistula or a graft, we're looking at 5 to 10 years that we can use that. You know, so it's very important that you look at a fistula graft, even though it is a little bit more difficult when you are on dialysis.
Another question is, before we get to Helena, we have one more question in the chats. How many people do you have that have had hematomas in their fistulas?
So
we could say that.
yeah, so what I'll say is that it's not, you know, we're taking a vein and we're pressurizing it. And if the needle that's going in makes a single pass to the dead center and stays there for the course of dialysis and comes out, you have a microscopic tract that should almost self-seal. The reality of real life is that sometimes that needle goes in too far and pokes out the back. You may glance off the sidewall and make a bigger hole, get dislodged during dialysis. All sorts of things can happen. And if blood comes out, it's under high pressure. It's from an artery. It'll get under your skin. It'll swell up right away and you'll get a goose egg there. But again, it's all under your skin. Hold pressure, it'll stop. Your body will reabsorb that over time. And this is why it's important to, you know, you want to, if that happens at this access site, you want to have a good working fistula that has lots of length to be able to move away from that spot. And same for grafts. Repeatedly cannulating the same spot will Swiss cheese the graft, do away with it, you'll become numb over top of it. So everyone wants the needle through the same spot every time because you stop feeling it. But it's a terrible idea because then you lose that ability. You'll start getting more and more bleeding and hematoma develop around there and will complicate your life in the long term.
So as a nurse in the hemo unit, what we've done to help prevent those hematomas or leaks or fistula blows is we're using sonocytes more often. We have a sonocyte that actually you can see where the needle's going, so that's decreased. We do have a program, it's called CRT nurses. These are nurses that are specialized, trained to start with the new fistulas, because you're going to have more incidences with new fistulas than the older fistulas because they're developing. They're not as large as they should be. So we do have a specialized trained team to do that. The other thing, and a lot of people don't realize that, is it's very important post-dialysis is to hold with 2 fingers and hold for your full 10 minutes, okay? A lot of people want to rush and go home. Well, it stopped bleeding on the surface, but it may not have stopped bleeding on the inside. When you puncture, you're going through the skin and then you're going through the vein. So you have to make sure that you're holding both the exit sites of the vein and the skin, okay? So it's very important. That's where you're going to get your leakages when you get home, and you're going to get your hematomas like that. So those 3 things have definitely reduced the number. It's not perfect. As I said, you have a new fistula, they're very gentle. Some of them are so fragile when they first start that you put a needle that sometimes they just blow, you know. But that's the important part of the vascular team. We're there to work with you. We talk to you about when you need to rest your arm. Let's not push it. We make sure that certain nurses are assigned to certain patients because they are difficult. So we try to reduce the amount of hematomas and any sort of leakage in your fistulas when we're using it.
So we're going to go to Helena, and then we do have another question in the chats. But Helena, do you want to come off mute and ask your question? Oh, she's actually not at her chair right now. So we will go to the question in the chats. Just back to it. So my dad had his fistula inserted, but he suffered a syndrome on his fingers. The doctor took it out, but now he is scared to get another fistula on the other arm. What is the best advice for him?
So the syndrome being referenced is likely Steele syndrome, which the name implies is when the fistula steals too much blood from the hand and leaves your hand without enough blood to be comfortable. And Steele syndrome can vary from mild, where it's only problematic on dialysis when the fistula is working and you might get some tingling in your hand, to severe, where from the moment you wake up from surgery, it's clear that there's not enough blood in your hand, it's uncomfortable, and something needs to be done. Grafts can be somewhat protective against Steele because we put them onto bigger arteries and bigger veins, but then sometimes people have real problems with grafts because because it's such a fixed size, and all of a sudden it's Steele, you know, it's borrowing half the blood from your arm to feed the graft. You can sort of have Steele transiently for a while that then gets better. I would say that Steele from a distal fistula that's done down at the wrist is an extremely rare event. And that if it happened on one side, it's like asking, you know, I'm worried that I won the lottery once, what are the odds I win the lottery twice, right? It's like statistics would say that if you had it on one side, that's just an unfortunate thing that happened. It would be very unlikely to happen on the other side, especially if it's at the wrist. The further up the fistula or graft comes, the more likely you are to overborrow because the pipes are getting bigger and the shunt will get bigger. So starting with a distal fistula can be protective against Steele. And it's important to know that some people may have Steele symptoms initially after surgery as their body accommodates to the fistula and this new change. But as Paul said, of the 11 people actively with Steele in the last period of time, 9 of them were just watching because yeah, they're tingly, but their hands are fine, they can move it. And especially with fistulas, as your body grows, because it's dynamic, the vein can expand and contract, your body will accommodate to that change in blood flow and the symptoms will go away. So we'll just observe it, and in many cases it will be resolved. It is the very rare person who needs to have their fistula abandoned altogether. It's a whole separate talk, but there's any number of procedures that can be done to try and, you know, what's happening is it's taking too much blood. So rather than throwing the whole thing out, oftentimes what we can do is something to try and reduce flow through it. Sometimes the solution is to band or narrow the fistula from the outside. Sometimes we move it from where it is further down the arm. If your connection's at the elbow, We may move the connection further down towards your wrist, put it on a smaller artery to limit how much blood it can take. There's any number of things that might be done, but it's very scenario specific, because in those cases, you're literally the 1 in 200 person. And so we got to figure out exactly what is it about you and your anatomy that's making this happen. And oftentimes there is a resolution.
Yeah, and I think the important part is the team that we have, because if you brought your father in to be assessed by a vascular surgeon and a vascular nurse, we're going to know that specifically. So we're going to do the ultrasounds to check both the radial and ulnar artery to make sure that we've got those good flows there, so it's safer. And we're going to have a discussion with you whether you want to change that or not. And if you do come for a consult, don't be scared to come for a consult, because you don't have to say yes at that point. You can always have the discussion first and think about it, okay? So, but especially in that incident where we've actually tied it off, which is extremely rare, we would want to have that time. We want to make sure that we do the proper ultrasounds and the proper tests to make sure it's okay. And as I said, the lower arm fistulas, if we can create here, are very rare that the Steele syndrome actually comes to that point.
So then the follow-up question is, a new fistula or graft could be inserted in the same arm.
Well, so Steele does not preclude the same arm. If you stole at the wrist and there was a clear anatomic reason, there are some people who have just one artery that goes to their hand because they've had cardiac surgery that's borrowed one before. Some people have like what we call a high anatomic radial artery, and so we may be boring from too big, and you could consider putting it in there. And certainly a graft is a good choice in people who've had Steele from fistulas, because the graft can't dilate over time. It's fixed at its size. And so we can intentionally put a graft onto a small branch artery and into a smaller vein to limit the amount of flow that goes through it.
It also depends how old the fistula is.
Yeah.
Because if we create it right away and it causes it, and it's so many years old, that's a little different, right?
So often, you see there's rarely people whose fistulas just keep growing. And so they're like fine originally, and then it just gets bigger and bigger and bigger to the point that it's stealing. And in those cases, we may keep your fistula, all those advantages of that, and just replace the first part of it with a tiny short little graft that acts like a choke to stop the amount of flow going through it. And then you still get all that good fistula access higher up. It really depends. And you wouldn't want to make any sort of decision about it without being seen by someone who does this a lot and who, does a real ultrasound and looks at your anatomy rather than just kind of, oh, your problem is this, then I'll do that. You could never decide what the intervention is for Steele without first assessing the person and seeing their anatomy before you. It's not really a telemedicine thing unless you've got a good ultrasound,
Okay, let's go back to Helena. Yeah, we'll get to that soon. Helena, do you want to come off mute and ask your question? I'm unable to take you off mute. Only you can do that. At the bottom or top of your screen, there's a microphone that you have to click on to unmute. And if you don't see it, you can always put your question in the chats and we can read it out loud as well. The chat is also at the top of your screen, a little bubble. If you want, you can also email it to us, just in case.
I think I'm on.
You got it. Good, good. Go for it.
I'm sorry I'm so late. I'm so sorry I couldn't come sooner. I'm wondering, my first question is this going to be recorded?
It is currently being recorded right now.
Okay,
and it will
good.
be on our YouTube channel. Don't worry.
So I'll be able to hear the recording.
Yes.
Okay, because this is important. So I had my operation for deep, this is my question, for deep veins. I had 2 operations and my second one was September 25th. So we're supposed to start cannulation around the 25th. But I have diabetes. So number 1 factor, deep vein. Number 2 is the diabetes. And I'm finding that my arm is still sore. It just doesn't feel like it's healed yet. So what's the protocol around? They want to start cannulation, and I'm nervous about that because I don't think my poor arm, my poor body is it's one thing after another. So what's your advice for, and contact, and the third would be contact information for accessing the expert on fistulas, because I have questions.
Okay.
So that's
So are you part of our program?
Yeah.
Which doctor do you see?
I see Dr. Lee is in Red Deer. Dr. Jim is in Red Deer. I don't really see anybody. They don't really see you in Red Deer.
Okay.
They just kind of swing by.
Okay.
So-
You need to contact your unit. Are you on dialysis right now?
Since May.
Okay, and you're doing it through a catheter in your chest?
The CDC, yeah.
You need to talk to your vascular nurse in your program.
Okay.
Okay.
Well, they're under a lot of pressure for time, and so I'm hoping to get a little bit of a baseline introduction. Like, this is incredibly wonderful to hear all the nuances, and I just want to get a little bit more of it, if that, because
So I think
referring me back to access is really not good for me. No.
so. The difficulty is, like, everyone's access is unique, and this is why, you know, these are rarely do your surgery and see you later kind of thing. You would ideally be followed in a longitudinal way by someone who is coordinating your access, and that will change from center to center and program to program. But it's very difficult to answer specifics about your arm, again, without having seen it in that. But I would say that secondary procedures that we didn't talk about, other than like branch ligations and angioplasties, is sometimes what you're alluding to, and that is that people have great veins, and they turn into great, they dilate up when you make the fistula, but the thing is just like a centimeter below the skin, and it's just too far. You can't grab it. You're not going to be reliably able to cannulate it. And so sometimes we'll do liposuction to clear the area on top. Sometimes we'll open your arm and do a transposition or elevation, which is a procedure to move it to a different part of the arm, or to bring it up by squishing the fat below it. There's all sorts of things that can be done to bring a deep but mature fistula closer to the skin to make it ready. And your relative recovery from that and ability to use it is really an individualized thing. But I would say the only thing that I could confidently say with, in sort of general terms, is that your arm's going to feel a bit different after surgery, and you should probably get started on trying it, because every day you have that line, you have a conduit from the outside world straight into the right side of your heart. That's where that tube ends, is in your heart, right? And as you can be the most fastidious and careful person about your line, but you are covered in bacteria for a living, and like something is going to try, and it has a cuff, and it has a Clorhex dressing, and all these things we do to try and minimize it. But every line stops working, either because of infection or because of that thing flopping around inside your heart and causing scar. And so if the team that is responsible for your care has assessed you and thinks you're ready to start, the only thing I can say in general terms without knowing you is I would try starting, because you're going to start eventually, and every day you have a line is a day that you're at risk of a problem.
I see. Will you be supplying, thank you. Will you be supplying your contact info for?
No, so because we're all local practitioners, we're providing this to a national audience. So I would start by reaching out to whoever coordinates locally for you, or the Kidney Foundation in general, for, again, who at least you can speak to closer to home.
No, that hasn't worked for me. I'm just
maybe that's something that we can explore offline, and if you have the email contact for the coordinator here, that can be followed up with separately.
Okay, that'd be great.
Perfect.
Thank you, Helena. I believe this is one of our last questions in the chats. Can someone on blood thinners use a fistula or a graft, or does it cause too much bleeding?
Yes,
Just thinking,
we have lots of patients. You can create a fistula. I mean, the willingness of your surgeon to create a fistula on thinners will vary from person to person. But there are lots of people who are on either antiplatelet medicines like aspirin, Plavix, ticagrelor, which is Brilinta, and that, who are accessed 3 times a week, no problems. And there are plenty of people on formal anticoagulation with, Pradaxa, rivaroxaban, Xarelto, warfarin, all those. It may just mean a few more minutes of holding pressure afterwards, but you can certainly be on thinners and have either a fistula or a graft.
And last word of advice from both of you to our participants watching that you
One
give.
more question.
Oh, okay. Go ahead. Do your question first.
It sounds like there's a lot of options in this. One question is, where do you go to find out what your options are?
The Ontario Renal Network has a lot of information about what is a fistula, what is a graft, and that. The Kidney Foundation is also an excellent place to go. They have information on that. And whoever you're dealing with locally within your hospital. Like I know anybody that needs any information, I will gladly spend time on the phone or even in person and chat with them about stuff. And I do have information on all these things. So, sometimes people are readers and sometimes people are, need a visual. So we can supply that. Also, the nurse navigators do a lot of teaching on modalities and that sort of thing within a neural. Yeah.
So I got one more first. Can I do my
No, she's saying she's the navigator.
Oh,
Yeah.
I'm sorry. Okay.
Yeah.
I thought she was saying me, my turn.
No.
The second question is, what do you do with the fistula or the graft after transplant?
Leave it,
Yeah.
leave it. Because until, if your fistula or graft isn't causing you problems, I would leave it forever because, if a transplant works great until the day it doesn't. And if you have, even if it's something silly, right? You have a transplant that's working well, you have a CT scan, you get an acute kidney injury, your transplant goes down for a bit, you need dialysis. If you have a fistula or graft sitting there, you just go back to old-fashioned dialysis for 3 months while your transplant gets over it, right? It's always there as a lifeline. Have I taken out? I mean, you can't take a graft out. That's miserable. But have I ligated fistulas and grafts for people who have, were dialyzing with a forearm fistula for 15 years before their transplant? They got aneurysms and that? Yeah, we can take it out then. But overwhelmingly, I would say if that's not causing you a problem, leave it to start with, especially in that initial run-in period, because if a fistula is like, a nice car, the transplant is like a high performance sports car. They need a lot of looking after and they can have problems. And so you want to have something in your back pocket that isn't a line, at least in the first kind of few years run in.
Yeah, and unless it's causing some sort of cardiac issue, we won't tie anything off or change anything. And just to note, the grafts we won't take out usually unless they're infected, because they are underneath the skin. We have to actually take the skin back away from the graft. It can cause a lot of incision issues and also nerve problems. So we always just leave the grafts in, so even if they quit. So,
Thank you.
You have a question? Oh, okay. So last words of advice from you two? Wisdom, advice?
I think everybody should have a vascular consult, even if they decide against it, just so they have that option. Because as I said, I think we both feel it's the best option for patients.
If you're going to do chemo and not PD, if you're going to do hemo, every decision is individualized, but you should at least explore a fistula, because in persons where it is a good possibility, yes, it's upfront work, and yes, it's a bit more work after, but it is overwhelmingly, both in regional experience and in international guidelines, a fistula is the most durable most long lasting, most infection resistant, most everything access option that you have. And you're not looking at dialysis. Very few people are looking at dialysis for 6 months. You should be looking at this with a long-term time frame, and making that investment up front in getting a fistula in and working will pay you dividends on the back end for avoiding problems.
And I want to make a point at Trillium Health Partners. We're actually very lucky to have 5 surgeons that actually create accesses. So Dr. McVeigh and the other group, we're very lucky to have so many that can create accesses. And we're also very lucky that we have the amount of interventional radiology time. So we actually really take good care of our fistulas and our grafts. So just know that if you have a fistula graft created, there's going to be a huge amount of team support there to make it work and to help you along with your problems. So, you know, we're, as I said, we're very, very lucky to have the team we have.
Great, so now we're gonna go into the simulation room for those that are interested and check that space out. So give us one moment and we'll take you along with us.
Yeah, go to your talk. I haven't seen this. That was good stuff.
Yeah, it was. Thank you very much.
Okay, I'll see you tomorrow morning. Actually.
Consult request 3:30. No, all is being recorded by the laptop.
Yeah. So here we have,
Did she name her?
yeah, her name is Annie.
This is Annie. So she is our model patient. Right now I'm showing you, this is known as a central venous catheter. Okay. And then we also have a fistula. Okay. Or it could be a graft. I'm not sure which one, but it still takes 2 needles. One needle takes the dirty blood away and then returns the blood via the venous port, and that's your clean blood, which goes through your dialyzer. So you can see this patient is using the arm, and look at, they've got the computer and they can use their hand in order to do their work because they can work from home. So this would be a typical home hemo patient in order to do their project or work from home while having their dialysis treatment. So you can see the machine. And this for home hemo for Credit Valley. These are our home machine that we use for our program. So it's known as the AK98. And during that time, we train you how to line and prime the machine if you're going to do independent dialysis. If you are not, we actually have a new program called Home Assist, where a nurse will come into your home, set up the machine, put in your needles or access your central venous catheter and run the treatment for you. So there are 2 programs to consider. So, and this is all followed by your home hemodialysis doctor and your home hemodialysis nurse. Only at Credit Valley. Anything else?
You want to talk about the renovation and things like that? You can talk.
Oh, for the home renovations, what they're going to do is, you can see the machine is set up here. They need to have plumbing and electrical set up.
Because of space constraint,
Here.
so
we have,
yeah.
So you'll need, the electrician and plumber will come in and you need 2 separate circuits. And this is all covered under the renal program. You'll need one for the machine and one for the WRO, which is your reverse osmosis machine. Okay. And then, so that will be a separate circuit. Then there'll be plumbing, which will be required. So they'll have is there one here, Neuro? Where's the one? There, that's the one I'm looking for. So this is your stack. We call it the stack, and it leads the plumbing into there. Okay, so we need water to go into your machine because it's very purified water that we use for your in order to make your dialysate. And it goes into your filter stand, cleans the water, and removes chlorine. Chlorine is a no-no for a dialysis patient, and that's why we have this filter stand. And I'll show you the filter stand here. We have the micron filter, the carbon filter, and on the back there's another 10-inch carbon filter, and the water comes in and goes through that and then goes into the WRO, which is your water purification system, and it goes through a very I'm having a brain break. It goes through the filter and goes rejected in and out and makes the water ultra pure. Okay. And then
I want to talk about the supplies.
And then our supplies. A lot of patients like to have a big screen TV when they're dialyzing. And so you'll need supplies like dialyzer, you'll need tubing, and you'll need bicarbonate. And here's what tubing looks like. Bicarbonate. And you'll need potassium bath and disinfection because you have to keep your machine clean by doing a disinfection after every treatment and every 2 days.
Did you talk about your blood work and centrifuge and everything else?
Oh, so then we have blood work is done. You're seen in clinic every 6 weeks to every 2 months by the doctor. And 1 to 2 weeks prior to that, we have a centrifuge that goes in the patient's home, and they're directed on how to do their blood work and storing of their blood work in the fridge. Oh, you're real. So we have storing of the blood work, and then the home hemo nurse will assist you in bringing it into the clinic and sending it to the lab. So.
Right.
And then during that time, when you do see the doctor, we review all your medications. We look at your treatment records in order to review your blood pressures to make sure you're doing okay as far as your weight, you're not fluid overloaded, or you're not having low blood pressures. Because the more dialysis that you have, the better you feel. Because the more dialysis you have, the cleaner your blood. So we have some patients that they do a longer dialysis, therefore then they can get off their blood pressure medications because they're better fluid controlled. So they don't need their blood pressure medications. And also the more dialysis you're exposed to, it actually can increase your hemoglobin. So you can actually get off your Aranesp or your EPREX. So they're all so many nice things. So, and also your blood work would look much better. Your creatinine will go down, and you'll actually get more energy. Okay.
All right.
So
thank you, Cindy and Nurul. Over to you, Uzma.
Hi, thank you everybody for joining us today, and thank you. Thank you so much. Yes, and just wanted to let you know about next month's meeting. It is on December 19th at 6 p.m. So please just go to the website and join as you did today. And looking forward to seeing you all. And that was a great presentation, and I hope everybody got a whole lot of information that you required. And if anybody needs to reach out, please do so to Sadia or to the Kidney Foundation. And looking forward to seeing you next time. Thank you. Bye, everyone.